will be available, right?
Yes, yes, absolutely. I'll send it to you.
Oh,
Don't worry.
yes, for a recall
So,
purpose, we can use.
yes, 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 yes.
Thank
So let's start. I'm Dr. Munjal. As you know, I'm hemato-oncologist and bone marrow transplant fellow, and
you. Okay.
practicing right now in India for last more than 20 years in hemato-oncology. So I'll give you the brief idea how to crack the questions, tips and tricks, right, rather than just mug up. So it's a very important session, right? So we're gonna do it very thoroughly with anemia part one by one and all important things, right? So let's start without wasting the time, right? Before that, I
Okay.
also give you the idea about few points later on various topics and all. So let's start with the anemia. So do you know the anemia definition? Dr. Fatima, you are welcome. We just started. Yes. Yes, Dr. Salika, do you know the definition of hemoglobin, white cell, or platelet, right? The definition of
Yes.
anemia, how you approach the anemia in general. If some patients comes to you, how you supposed to approach to anemia?
So, based upon symptoms and the blood test we are doing,
Okay, fine.
so
So we will go very
we are.
systematically. So what happens? I
Okay.
myself has given the Viva in Oman few years back, right? So
Mhm.
so whenever there are a case scenario they had given, right? That say for
Mhm.
example 25 years of female presented with excessive menstruation and presented with the history of weakness, fatigue, easy fatigability, how you approach, this is what they will give you, how you approach the patient, right? So basically you have to go very quickly in any, this is general for all questions of Oman Viva. So you have to know the quick history of the patient, if any significant past medical history or surgical history related, right? And then related labs you need to know. Once you know these details, you're gonna get the diagnosis. You're gonna get the diagnosis, right? And on diagnosis, you will going to treat the patient, right? So this is how works flow, right? So you need to know the very quickly. You have hardly 10-15 minutes in Oman Viva, right? To cover up everything, right? So you have to be very specific, right? Whatever you don't know, you just give the answer that okay, I don't know, right? But you don't give the improper or wrong answer because they are brilliant people, no? That is why they are sitting there, right? So
Yes.
don't try to make them fool. I mean, try to give the genuine answer that okay, fine, I don't know, I don't remember now. So let me start and we'll discuss the real scenarios, right? How you supposed to give the answer in exam. So approach to anemia, any anemia approach you give to, this is all clinical. I made it by my experience over last 20 years of extensive hematology practice. So this is all practical point. So you need to right. So I made this acronym approach to anemia. How you supposed to approach the anemia. So there are five words CATTF. C stands for cause. So you need to find out what is the cause. How you supposed to find out? By history, by examination, by CBC, MCV,
Yes.
peripheral smear, and probably the reticulocyte count, right? So this is the cause. You need to know the cause. Once you know the cause or possible cause, right, by the history, examination, and basic lab, right, you need to go for some kind of specific diagnostic workup, right? Another, so
Yes.
C means cause, A means assessment of anemia or diagnostic workup of anemia, T means transfuse or not. It's a very important in any anemia patient where and how you supposed to transfuse. If HB is 5, at that time you transfuse, 6, 7, 8, 9 or less than 10 you supposed to transfuse. So you may need to know the range, right, where we supposed to transfuse the patient. Treat, right? So CATTF, cause, assessment of anemia, transfuse or not, what is the treatment, right? So treatment of underlying cause, right? So depends on cause, you need to treat it, and follow up is extremely important in normalization of hemoglobin. So this is bottom line in any anemia patient, any patient you see for the such patients in your practice, you need to ask this way 5 questions to yourself. Number one question is what is cause? Means C, you need to assess and diagnose, transfuse or not transfuse, treatment and follow up. Is that clear to everyone? Yes or no? Dr. Fatima, are you getting me? Right. So this is the things, right? So this is a common hematological this values we must remember because sometimes we don't know the actual normal value, right? So in man, the normal value is 13 to 18, right? Right. So 13 to 18, and woman is 11.5 to 16. So many a times doctor know though 10 is normal in female. So 10 is never a normal in female. The normal range of female is 11.5, right? It's obviously
Yes, sir.
lower than their menstruating. So it is lower than man, right? So men
Excuse me,
normal
sir.
hemoglobin.
Sorry.
Yes. Are you getting me? Yes or no?
Excuse me, sir. Can you hear me, sir?
Yes, we can hear you.
Okay. Okay, sir.
So you can interact with me. Don't worry. Or if you find something, I mean, you want to ask me, you can stop. Don't worry. So hemoglobin normally in man or male is 13 to 16, and female is 11.5 to 16. This is normal range, right? So number one, this we need to know. Second important thing is mean corpuscular volume, MCV, mean corpuscular volume. That means average size of RBC. Average size of RBC. So what is average size of RBC? So normal is 80 to 100. 80 to 100. The unit is femtoliter. FL, femtoliter. Right? So 80 to 100. This is what we supposed to know. Third thing. Platelet we know already 1.5 to 4.5, and WBC is 4,000 to 11,000. It's a normal limit. So this is absolutely a common hematological value which we supposed to know. Without knowing the normal, how we supposed to know the abnormal? So this is very important slide for us to know. So our job would be easy, right? We never ever
Yes.
wants to mug up the things. We need to understand the complete concept, right? If we understand the concept, we can answer any question, right? So this is one thing. Second thing, if you going through the anemia, there are extremities, right? In anemia CBC interpretation, right, there are two extremities, right? Hemoglobin, white cell and platelets. So what is first extremity? Is HB is low, it is called anemia. HB is more than 20. I recently even treated patient with 21 hemoglobin just last week. Sorry, it's turned to be polycythemia vera. So low hemoglobin anemia, high hemoglobin is polycythemia vera. Low WBC count is leukopenia, high WBC is leukocytosis, right? And low and high means right, it's out of the range. Say for example 4,000 to 11,000 is WBC. So less than 4,000 is leukopenia, more than 11,000 is leukocytosis, and platelet is 1.5 to 4.5 lakhs is normal. So less than 1.5 it is thrombocytopenia, more than 4.5 is thrombocytosis or thrombocythemia. And if all the three things are low, it is called as the pancytopenia. Is that clear to everyone? Yes or no?
Yes.
Yes, sir.
Wonderful, right? So this is also very important, though it's easy things, but we need to know. And this is the most important, the MCV, that is called mean corpuscular volume, right? So normal is 80 to 100 femtoliter, as I told you, right? That is called normocytic. Normocytic, two word, normocytic. So this is normal RBC. It's a dumbbell shape, biconcave dumbbell shape. Just for your knowledge, huh? This is normal, right? Is say for example, is MCV is 90, normal is 80 to 100. You supposed to know 80 to 100, as I told you earlier. If it is small RBC, say for example, is MCV is 65, it is a small, and something is 110, MCV is 110 femtoliter. This is large. So there are two things. Small size, small, they use the word micro, and for size they use the word cytic. So this is microcytic. Here this two word normal size, so normo, and size is normal. So small size, normal size, large size, normocytic. Large size, so it is macro means large. This is 80 to 100 is baseline. So this is large means macro and cytic means size. So cytic would remain the same. Cytic size, word cytic. If it is normal size, normocytic, small size, microcytic, large size, macrocytic. Is that clear to you? Yes or no?
Yes.
Yes, sir.
Fatima, are you there? Is it
Yes,
clear
sir.
to both of you or not?
Yes, sir.
Wonderful.
Yes, sir.
Wonderful.
Yes.
Wonderful. So this is what about the microcytic, because the whole classification of anemia is on MCV. We're gonna see it very soon. So this is the basic things. Without knowing the basic things, we can't jump onto the main part, right? So this is a classification of MCV. We'll see it later on. So now let's jump to the first question with the concepts of anemia. Now we know what is the normal CBC, hemoglobin, white cell, platelet, MCV, right? So we'll see, we apply. I'll ask you the questions to both of you, right? How you supposed to think and what is the answer, what they expect, right? So this is very quick question. Say for example, I'm your examiner and I'm asking you. So let's start with you, Sakila, and second questions I'll ask to the Dr. Fatima. So you get ready, Dr. Sakila, Salika, sorry. 25-year
Yes.
female, right? So this is real scenario in front of you in your exam, that 25 years of female who has no comorbidity, otherwise fine. She had a history of three delivery. She presented with you with the history of heavy menses. You examine the patient. There is no fever, right? No bleeding from any other side by history. Weight loss is not there. Examination is marked failure. Her RS CVS is no, not significant, is essentially normal. For abdomen is soft, non-tenders. Neurological examination is also normal. How would you manage this case? So this is simple one-liner question, right? To you comes in your exam. How are you supposed to manage this patient? Yes, tell me. Your time starts now.
Okay. So the patient has a heavy menstrual period, so causing excessive blood loss. Uh, we're going to ask history, everything is there. So next, I have to go for examination. I want to know whether there is any fatigue history, like fatigability is there, anything, tiredness
Yeah, so
associated with this.
patient has a history of fatigue, easy fatigability, easy fatigue.
Okay.
Patient has history
So
of easy fatigue.
um,
Okay.
uh, so because of heavy menstruation, there will be excessive blood loss that might lead to anemia, and that is causing the fatigability. So we need to confirm whether she is anemic. We can examine and we can look for pallor in the eye, and
Sorry to
how is
stop
that?
you here. 1 second.
Yes. Uh,
See, everything is given here, so you don't need to ask again. They have
okay.
already
Okay.
told you that 25
Just go
years of
for
female, no comorbidity,
okay.
three delivery, heavy menses, easy fatigability,
Okay.
no history of
Okay.
fever, no bleeding from any side, other side, or weight, like no other side with no oral bleeding, no glum bleeding, no bleeding per rectum to rule out the piles, right, or hemorrhoids. Patient has no history of weight loss. If weight loss is there along with the anemia or suspected anemia, it could be malignancy, right? So there is no
Yes.
history.
Yes.
Examination is pallor. Rest of the examination is essentially normal, right? Including
Okay.
RS, respiratory system, cardiovascular system, for abdomen soft, no hepatosplenomegaly, right? And central nervous system is no abnormality detected or essentially normal. How you manage the case? So you
Okay.
can start again, right? So whatever is given in
Okay.
the scenario, you don't need to waste your time to ask again pailer. They already given you,
Okay. Okay.
right? Whatever
Okay.
you just ask only that question which is important for the diagnosis, which is important for the treatment, because whatever you ask, they will stretch you in that questions which you probably don't know. So I will give you the example, right? How they track the Viva, how they divert your Viva to some other subjects, which you don't know. They want that things only. You do some mistake and they will divert your Viva, right? So once again, this is the scenario. Your time starts now. I'll give you 2 minutes. I'll give you 30 seconds to think and format the answers in your brain and mind, right? Give you 30 seconds. I'm not in hurry at all. We'll take 2 hours lecture. Don't worry. We need to learn the real medicine. We need to learn the real answer and the art of giving the answer, because you have hardly 10 minutes in Viva. Your first question is the most important impression for them. They decide whether you will going to pass or not in first question. If you first answered, you did not answer well, okay. Second, not well, 99% you are gone. You understand? So our
Okay.
first question's
Yes.
answer should be so appropriate, so impressive that they make their mind that I would like to pass Dr. Salika. That's it. That is what in just 5 minutes.
Okay.
This is a matter of 5 minutes. So I'm giving you 15 seconds. This is the details, right? And I will ask you the mistake. We'll make a list of the mistake too, right now, right? What you supposed to
Okay.
you, what do's and don'ts, right? What you need to do. I mean, you means you and Fatima both, we need to learn.
Mm.
So take your 10-15 seconds, format the question, answer how you manage this case, and then we'll discuss. Take 15 seconds.
Okay.
Then you get ready, Dr. Fatima.
Okay. Can I can I say something?
Yes, Salika, start.
Yes. Yes.
So this is the
Okay.
scenario, right? How you manage this case, doctor. Go ahead.
Okay. If the patient is right now bleeding acutely, I would like to, I need to check whether the vitals are stable. And then I would like to give, if she is currently bleeding, I might have to give her tranexamic acid. And I want to check whether she is having any anemia. And if she is anemic, based on the level of hemoglobin, I have to start treatment. If it is 10 to
So
8, I might give her
how
supplementation
do you
with
diagnose the anemia? Because patient has a pallor, so there is a
failure.
possibility that patient has a anemia. So how you confirm
Okay.
the anemia? What are the tests to
Uh,
confirm the anemia?
yeah. I need to do CBC first.
CBC. Okay, fine. So in CBC, they will give you the one strip, or they will give you hemoglobin is of 6 grams, MCV of 60, total count is of 6,000, and platelet count is 600,000.
Okay.
Now this is
So,
the CBC,
uh,
doctor. How you want to approach? What else you want
okay.
to do? You ask for the CBC, CBC showing this. Anything else you want to do?
mm, TIBC, ferritin, TIBC,
Sorry,
serum ferritin, sir, ferritin, TIBC.
ferritin, TIBC. Okay, what else you want to do for this patient?
Mm,
These two things. Okay, so ferritin is 10, ferritin is 10, and TIBC is 350.
okay. Mm, vitals normal, right? Vitals.
Yeah, vitals normal. Vitals normal. And this is a heavy history of heavy menses. Just for your kind knowledge, right now patient is not heavily bleeding. Right now,
Okay.
not heavily bleeding. She had a history of bleeding. So 25 years of female, no comorbidities means no hypertension, diabetes, or any other major illness. She had a history of 3 delivery. She had a history of heavy menses, but not now. But now she presented with easy
Oh,
fatigability, right? She has no fever now.
yes.
She has no bleeding, no weight loss. She has a pallor, no icterus, no lymphadenopathy, no hepatosplenomegaly. RS, CVS for abdomen and CNS is essentially normal. How you manage the case? So you answered you want to do the CBC. So this is the CBC. So doctor, tell me on this CBC, what are the differential diagnoses? This is a CBC. So what are the differential diagnoses on this CBC?
Mm. Looking at the CBC, the patient is having a severe anemia because HB is 6
Okay,
and
fine. So patient
MCV
has a
is
severe
low.
anemia. Severe anemia.
Yes.
Wonderful. So what are the differential diagnosis of 6 anemia with this CBC? So if someone gives you this CBC, I have a few 5 or 6 differential diagnosis. What are your differential diagnosis on this CBC?
Um, Most
Or
first
or
important
or
thing is
or 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 else I ask you, right? Hemoglobin of 6, HB of 6 with MCV of 60. What are the differential diagnosis? Tell me the differential diagnosis. Forget
most
about
common
this
is iron
scenario. Tell me.
deficiency. Okay,
Most common is
okay.
iron deficiency anemia. What
Deficiency
else?
anemia.
Number one. Number two.
Then excessive blood loss,
Okay.
like
Excessive blood
menstruation.
loss. Usually in excessive blood
Then,
loss, the MCV is usually normal, doctor. MCV is usually normal for your knowledge, right? So
okay.
excessive blood loss. So somebody say, for example, a patient is this patient, Mr. John, who has a hemoglobin of 14 grams, MCV is of 90, means normal, no anemia, normal MCV, normal individual. He has a bad, very bad road traffic accident, massive, and he has a major fracture, external bleeding, right? He came to emergency room. Now his hemoglobin is 8 gram, right? But MCV won't change within 1 minute. It will remain the 90.
Yeah, it will be normal. Yes.
It would be
I
normal. The
mean,
MCV is
chronic.
normal, right? So
Okay.
excessive blood loss usually they usually don't have low MCV, right? What
Okay.
I'm asking you, the question, my question is specific. What are the differential diagnosis of low hemoglobin with low MCV? Dr. Fatima. Meanwhile, Dr. Salika is thinking, tell me the differential diagnosis. What are the differential diagnosis of low MCV with low hemoglobin?
Sir, iron deficiency anemia
Wonderful. So one she told iron deficiency. What else? Second,
and
second,
thalassemia. Thalassemia,
thalassemia.
sir.
Okay, thalassemia. Second, third,
Sideroblastic anemia
brilliant. Sideroblastic anemia. Third, fourth.
and sickle cell anemia, sir.
So that all comes in the hemoglobinopathies. Thalassemia, sickle cell anemia. So that comes in the hemoglobinopathies. Okay, fine, fair enough. What else?
Lead poisoning, sir.
Sorry, lead poisoning. Anyone else? Last. There are 5 causes. Anemia of chronic disease, right? So let me give you the idea about this all things, right? So let me uh, give you the more in-depth idea about this. So yes, can you see my screen or not?
Yes, sir. Yes, sir.
Yes, sir.
Wonderful, wonderful, fine. So first of all, anemia. How we get to know anemia is by hemoglobin, because in CBC there is a hemoglobin. Hemoglobin is right. Then white blood cell, also platelet count. It is in CBC, right? And there is MCV as well, right? So our hemoglobin was 6 and MCV was 60. So what kind of anemia it is? Microcytic, normocytic, or
Microcytic anemia.
macrocytic,
Micros
right? So it
micros
Microcytic.
is microcytic anemia, right? Because MCV is less than 80 to 100 is micro, 80 to 100 more than 100 is a macro. So this is microcytic anemia. Microcytic anemia means RBC is smaller than the normal size. It's smaller, right? So there are 5 differential diagnoses of anemia. So anemia can be defined, right? Anemia can be defined on MCV. If you go by just only one word MCV, you have 3 possibility: low MCV, low MCV anemia, there is a normal MCV anemia, right? And there is a high MCV anemia. Are you getting me? Yes or no? So
Yes.
anemia
Yes,
is
sir.
there, means hemoglobin. So 6 hemoglobin, if you have low HB, low MCV, how you manage? If you have 6 hemoglobin, normal MCV, how you manage? If you have 6 hemoglobin, increase MCV, how you manage? So we have the scenario low MCV. So there are five acronym. Iron last. Just for your remembrance. Iron last. LAST last. Last iron. This is so whenever you comes in the practice, low MCV with anemia, remember five. Iron last means iron deficiency anemia. Second most common after this is anemia of chronic disease. After that is thalassemia or hemoglobinopathy. Thalassemia and sickle cell anemia. L means lead poisoning and LAST sideroblastic. Sideroblastic. Is that clear to you? Yes or no? Yes or
Okay,
no?
sir. Yes,
So
sir.
Yes,
you
sir.
need to remember iron deficiency, lead poisoning, anemia of chronic disease, sideroblastic, and thalassemia. What are the commonest globally? If you have somebody, so if you have any patients of low MCV and anemia, first rule out the iron deficiency, number one. Second, rule out the anemia of chronic disease, most common in clinical practice, and especially in pediatric age group, is thalassemia. After that, fourth is a sideroblastic anemia or myelodysplastic syndrome, and fifth is a lead poisoning. In terms of
Okay, sir.
incidence and prevalence, right? How do they
Okay.
present? So if you see, if I see in my practice 100 patients of low hemoglobin anemia plus MCV, I can get 60, 70 up to 80% is iron deficiency. 15-20% is this, and rest of the these things are 5-10%. You got the idea? Yes or no? You got the idea?
Yes.
Right? So now you have five things, right? So iron deficiency, if you are thinking you want to rule out in this lady who is excessively menstruating, the past history of excessive menses, and now easy fatigue, now presented to you with 6 HB and MCV of 60. You want to rule out the iron deficiency. So first, what test, Dr. Fatima, you supposed to order for this patient?
CBC, sir.
Sorry?
CBC.
No, CBC is done, na, doctor. CBC we already done. Hemoglobin 6, WBC is 6,000, platelet count is 600,000 or 6 lakhs, MCV is 60, right? Now this patient has what is abnormal? Hemoglobin low, MCV low, anemia approach by MCV. First commonest cause is iron deficiency that you want to rule out. 6
We have to
HB,
go for
yes,
ferritin level, sir.
ferritin level. Okay, so ferritin level comes and ferritin level comes 10. So what is the normal ferritin range, Dr. Salika and Dr. Fatima? What is the normal ferritin level? What do you mean by
More than
ferritin?
50, sir.
Sorry,
More than 50.
more than 50. Okay, so what's your answer, Fatima?
More than 50, sir.
More than 50. Oh, sorry, you told. Yes, Dr. Salika, what's the normal ferritin level in the blood? If somebody checks
Uh,
your and my level of ferritin, what is the normal ferritin level in our body? Or you can talk in the female. Normal ferritin level in female in menstruating woman.
mhm.
Yes,
I
yes.
don't
You
remember.
know, fine. So you need to remember all the three things. It is basic. So write down both of your homework. Right. You need to know
Okay.
ferritin, TIBC, and iron. What is the normal level? Right.
Okay.
All right. So this is very important. Right. So normal level of ferritin for your kind knowledge, normal ferritin range, menstruating typical reference range of ferritin is 1515. Remember 15150, 15150. This is normal ferritin level, right? But this is normal ferritin level. So anything less than 10, but many books suggest less than 30 is considered as an iron deficiency. Less than 30 is considered below, right? is a is called as a low store. Ferritin shows the store of the iron, store of the iron. It is stored in the reticuloendothelial system. So ferritin is a store, right? Like you are depositing the money in the bank. Bank is your storage. Like that, the ferritin, right? So low ferritin means there is a there is a low storage. low storage. So this is the most important diagnostic criteria for iron deficiency anemia. If your ferritin is less than 30, there is no differential diagnosis, right? Other than iron deficiency anemia, right? So you evaluated this patient, and this patient has a 10 ferritin, means it is iron deficiency, right? Patient has a low HB, that is anemia. So you make a diagnosis only by one parameter, ferritin. Though you can measure ferritin, you can measure the TIBC, you can measure serum iron, you can measure soluble transferrin receptor, many things we can do it. But if the ferritin is the most important, so number one, what you do in suspected case of iron deficiency anemia, just do the ferritin, right? And if the ferritin is low, it is none other than only one diagnosis is iron deficiency anemia. Is that clear to Salika and Fatima? Yes or no?
Yes.
Sir.
Okay. Now say for example, patient has a normal ferritin. Could it be iron deficiency anemia? Yes or no? First of all, answer is yes or no.
Yeah, it can be.
Salika, if you have a
No,
normal
sir.
ferritin, no, there, there,
No.
there is no iron deficiency. If the ferritin is normal, that means there is no iron deficiency. Yes or no? What do you think, Fatima? Same scenario. Instead of this, ferritin is, say, for example, here
Ferritin is
30.
normal. It is not iron deficiency anemia, sir.
Fine. So let me tell you, ferritin is a acute phase reactant, right? These all are word are high yield word. It is acute phase reactant. Ferritin. It can increase in infection. It can increase in inflammation, like fever. Your body is not well. Autoimmune disease, right? Some kind of leukemias or some other things, right? This ferritin can goes up. So somebody has a 104 fever, 104 fever, and check the ferritin. Ferritin is elevated. And if you check the hemoglobin, hemoglobin is 6, MCV is 60, but ferritin is 150. So you think that there is no iron deficiency? Anemia is there. HB6 means anemia, but you want to confirm it is iron deficiency. You check the ferritin, it is 150. So you are confused. Oh, it is too high or it is upper normal. It is not like that. So it is wrong parameter, especially in infection and inflammation, right? So whenever there is an infection and inflammation, ferritin will not give you a real idea. In that case, you need to do the TIBC, total iron binding capacity. If the TIBC, what happens to TIBC in iron deficiency anemia? Normal,
Increase.
No, sir.
increase or decrease?
Increase.
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 Wonderful, increase, increase. So now iron deficiency anemia patient who has no fever, nothing, everything is fine. If you do ferritin, it is usually low. But iron deficiency anemia patient develop 104-degree fever, comes to you. Here, no fever, HB6 and MCV 60. Here, same thing, HB6, MCV 60, 104 fever. Here, without fever, you check the ferritin. Ferritin is here 10, and here the ferritin of the same patient is 150. That does not mean that this patient does not have iron deficiency, because fever, infection, or inflammation, it's an acute phase reactant in which, right, the cell releases the ferritin to the plasma, right? So it is falsely elevated, right? So it is not a good idea to check the ferritin while there is acute infection, inflammation. You may confuse. What happens? You treat this patient, he is absolutely fine after 7 to 10 days, and you check the ferritin, this 150 will come to 15. Is that clear?
Okay.
Yes or no?
Okay,
Is
sir.
that clear?
Yes.
Right?
Yes.
So always have a suspicious eye, right? So what happens? So this is your diagram. This is your diagram. What's your diagram? This is your diagram. So whenever you have a, yes, so whenever you are going to do this such a things, what you do, right? Let me erase the slide. I cannot add the new slide with the blank things. Okay, all slides are coming like this only. Fine. So whenever you want to do the things, right? So let me erase this part. Right. So now you have a clear picture. So you have a HB of 6, MCV of 60. You are thinking it could be iron deficiency anemia. So what you did a ferritin. There are two possibilities. Ferritin is low, it is confirmed iron deficiency anemia. This is here the story is over. If the ferritin is high or normal, still you are suspecting is iron deficiency anemia, right? The next test you can do is TIBC, right? If the TIBC is high, it is iron deficiency anemia. If TIBC is low, it could be anemia of chronic disease. Is that clear to you? Yes or no? So it has this
Yes.
TIBC is not acute phase reactant, not acute phase reactant, while ferritin is acute phase reactant, acute phase reactant. So it can be change in infection, inflammation, dehydration, malignancy, some drug interaction, blah blah. While TIBC is not a acute phase reactant. So if you do the ferritin and if you have low ferritin, your job is done, right? Whatever the other parameters come, it is iron deficiency anemia, right? But what if it is high or normal, right? There are three possibilities. Ferritin could be low, it could be high, it could be normal. So in that case, you do the further test TIBC. If TIBC is high, it could be iron deficiency. If it is low, then it could not, right? Because it is not suggesting the iron deficiency, right? So it could be anemia of chronic disease. So here the diagnosis could be chronic renal failure, right? Here could be chronic renal failure. So any patient who has a chronic renal in general, right? So they may have some risk factor of hypertension, diabetic, analgesic, nephropathy, or some renal disease, or something is there in the history, right? But this is how you're supposed to manage and answer, right? So this is one differential diagnosis is iron deficiency anemia, right? So now you have complete picture. 6 MCV, 6 HB MCV is this. Ferritin is of 10. Even you do the TIBC, TIBC is high. So this is classical iron deficiency anemia. Is that clear? Yes or no? At least tell me yes or no.
Yes.
Here
Yes,
you
sir.
have missed two parts when, right? So you how you supposed to answer in exam any hematological problem with abnormal CBC, whether in hemoglobin, whites or platelets, CBC, ask for the peripheral smear. Extremely
Peripheral
important.
smear, right?
Any
Okay.
condition can be diagnosed from the peripheral smear. Let's say, for example, iron deficiency anemia. So how the peripheral smear picture will come? Hypochromic,
Micros.
microcytic,
Micros.
right? Teardrop,
Yes.
target cell, blah blah blah. Long description of iron deficiency would be there because they can see the peripheral smear of your blood into the microscope. So by knowing this also you get the confirmation, right? It is iron deficiency, right? So CBC is not only the investigation, CBC is incomplete without peripheral smear. So this is take home message from my side. Whenever in your family or friend anything goes wrong in the CBC, either hemoglobin is abnormal or white blood cell is not abnormal or platelet count is abnormal, always ask for the peripheral smear. Always ask for the peripheral smear. If the patient has a same scenario, 6 HB, patient has a 660 MCV, patient has ferritin of 10, but in peripheral smear they mention that patient has a 10% of blast looking cell. Blast looking cell. What could be the diagnosis?
Um, Ilo,
Sorry?
Myelodysplastic. MDS.
Yes, Alika. So peripheral smear
My,
is commented that peripheral smear showing, right, the normochromic red blood cell with 10% of the blast cell in the peripheral smear. Yes, Alika.
I'm not sure. Myelodysplastic syndrome, sir.
Myelodysplastic. Okay, I'll write down. Don't worry. This is discussion. You open up. You tell whatever the answer. This is practice. I don't want you to repeat in the exam. So MDS. What
Okay.
Dr. Riaz Fatima you are thinking? What could be the suspicious from the blast cell? Yes.
Leukemia, sir.
Sorry.
Leukemia.
Wonderful, brilliant. So, Dr. Salika, first impression is leukemia, right? So normally in peripheral smear, the blast is 0% in peripheral smear. If somebody does my CBC and do the peripheral smear and see and if somebody is trying to find out the blast, 0% in peripheral, and in bone marrow, right? In normal peripheral smear, 0% blast, right? So blast percentage in peripheral smear is 0, and bone marrow percentage of blast in bone marrow is less than 5%. And peripheral smear or bone marrow, if the blast cell is more than 10%, right, suspicious of leukemia, and more than 20% blast in peripheral smear or bone marrow is 100% confirmed it is acute leukemia. Is that clear? Yes or no? At least tell me yes or no. Yes
Yes,
or
sir.
Yes.
no?
Yes, sir.
Fatima, is that clear?
Yes.
So
Yes, sir.
see the importance of the peripheral smear. 6 HB, MCV 60, low ferritin, looks like, but see the whole picture is changed. So in this patient, I would like to do a bone marrow biopsy to confirm acute leukemia. And if the blast is 0%, obviously in iron deficiency, who will going to do the bone marrow? Who will do? Nobody will do. I never did it in my 20 years of vast practice. I seen thousands and thousands of anemia, right, of all extremity, 1 gram hemoglobin, 20 grams, all pancytopenia, whatever. You give me the any CBC, I can diagnose in 1 minute. Any CBC you give me, random CBC you give me, I'll diagnose without doing any test. I can tell you the differential diagnosis. I can tell you, believe me, right? So it's very important. This is the importance of peripheral smear. So if somebody doesn't tell you the peripheral smear, you are giving iron. It is not improving. Why not improving? Because there is a blast. It's a leukemia. So it is possible. Patient has two things: leukemia plus iron deficiency anemia. It is not possible. What do you think? It's not possible.
It can be.
Salika, it's not possible that one lady who has iron deficiency anemia as well as leukemia. It's possible or not possible?
Possible,
It
sir.
can be.
Sorry,
Yes, it can
Possible.
be.
right? So it's possible. Like one patient has a hypertension. After 2 years, he developed diabetes. After 3 years, he developed hypothyroidism. After 5 years, uncontrolled diabetes can ischemic heart disease. If blood pressure is not controlled, he may develop stroke. Is that clear? Yes or no?
Yes,
Yes.
sir.
Right? So one patient can have two pathology. It is your job being a doctor to find out all the pathology, why it is wrong. And that is why I told the CATTF, cause, assessment, right? CAT means transfuse or not transfuse, treatment and follow-up. So follow-up is extremely important until and unless your hemoglobin is normal, right? So you need to ask along with the CBC. Peripheral is 100% mandatory in clinical practice. Is that clear? So now let's go back to the
Yes.
questions again, right? So this patient has a 6 of HB, right? MCV of 60, right? Total count of 6,000, total count or total white WBC count, and platelet count is 600,000. Now see the peripheral smear. If the peripheral smear is showing hypochromic microcytic, right? Another description of iron deficiency, my diagnosis is iron deficiency. If the peripheral smear is showing there is an increased number of blast cell, I'll think of leukemia. If they are showing lots of target cell and low MCV, I may think of hemoglobinopathies or sickle cell anemia, thalassemia, right? If they are showing there is a hypochromic microcytic, also there is a few macrocytosis, megaloblast, macroovelocyte. I may think of iron deficiency plus B12. This is classical. So iron plus B12, the name is dimorphic. Dimorphic. What do you mean by dimorphic? Di means two. Two. And morphic means morphology. Two different morphology. Iron deficiency, one, and another is B12. So two different etiology under one slide is dimorphic anemia because they have peripheral. This all are what we are discussing in peripheral smear. Myelodysplastic syndrome, you told by, so you may see Pelger UA abnormality. You can see multilobated nuclei or hyper segmented neutrophil, hyper segmented, right? Multilobated platelet count or giant platelet. Are you getting me? Yes or no? Are you getting me? Yes or no?
Yes, sir.
So see
Yes,
the
sir.
how the
Yes,
peripheral
sir.
smear. So any condition can be diagnosed. This is what I learned in many years of practice of hematology. So only if you see, if you tell me this, my diagnosis will be this. If you tell me in peripheral smear this, my diagnosis is this. If you tell me this in diagnosis is this. If you tell this, my diagnosis is this. MD is this. So peripheral smear is extremely important, right? And if this patient in peripheral smear, if HB6, MCV6 and peripheral smear, there is a ring-shaped malarial parasite are seen. This is classical ring-shaped, the ceremony ring, right? Ring-shaped. It is P. falciparum. Can seen in the microscope. My diagnosis is P. falciparum malaria, not iron deficiency anemia. Patient has a fever, patient has 6 HB, patient has a 60. So he could be have both the things, P. falciparum malaria plus iron deficiency, right? So if you do the ferritin, ferritin is low, but you also see the P. falciparum. So you treat the P. falciparum. After that, you treat the iron deficiency, then HB will become 6 to 13 or 12. Is that clear? You have two etiology. You have a ladies or any lady in the planet until proved otherwise she is iron deficiency, including both of you. You go and check your iron deficiency. 99% you have iron deficiency anemia. Hardly 2 out of 10 has normal iron profile. 7 or 8 female in India especially, right? Or Indian origin, they have iron deficiency anemia. Two reason, dietary intake is not good. Second thing is menstruation every month, right? Throughout their whole menstrual cycle, right? Probably from age of 15 to 45. So 30 years they are menstruating, right? So it's a cause of iron deficiency anemia common. So this is how the completely picture may change of this explanation. I'm going to give you the complete real idea how the treatment plan or how the diagnosis will change. So let's come hemoglobin is 6 gram of HB, MCV is 60, total count is 6,000, platelet count is 600,000, peripheral smear is showing hypochromic microcytic, right? And hypochromic microcytic, you do the iron profile, ferritin is just 10. How you approach this patient? How you approach this patient, Dr. Salika? Now you have complete profile, you have history, you have examination, you have vitals, you have systemic examination, you have lab, you have everything now. How will you manage this patient? How you gonna manage this patient? Or any other investigation you would like to do? So this is a case by yourself is iron deficiency. How did you get to know? The name itself suggests two words, iron deficiency. How you know? Ferritin. Anemia, how you get to know hemoglobin is low? So compiling these two words, iron deficiency and anemia. So you confirm both iron deficiency by low ferritin, anemia, the definition of anemia is less than normal hemoglobin. So 6 hemoglobin and 10 ferritin means it is iron deficiency anemia. Now, would you like to investigate further for this patient or directly you jump onto the treatment for this patient? And if want to investigation, what investigation and why? If you want to treat this patient, then how you supposed to treat this patient? Option is oral iron. You want to give iron deficiency, so you want to supplement the iron, right? Salika, are you
Yes.
getting me?
Yes, sir.
Oral supplement you can improve. Intravenous iron you improve. Blood transfusion you can improve. And erythropoietin you can improve the hemoglobin. So out of the four options, what you can what you would use for our patient?
Um, I will do blood transfusions because HP is 6. It's severe anemia.
Okay, so blood transfusion for this patient, right? Dr. Fatima, what you want to do for this patient?
Sir, IV iron, sir. First, we have to go with IV iron, and
Okay,
then we have to switch it to oral iron.
okay, so you want to start your first treatment is IV iron and second treatment would be oral iron. Okay. You can't do Dr. Fatima that you start with the oral iron and if no improvement and then you can go into the IV iron. Reverse. Just trying to understand. Just trying to understand.
Yes, 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 sir. The hemoglobin is very low, sir. So, and
You
she
give your
have
answer, you give your
history of
experience,
epileptic.
how did you did in last so many years of your practice. This is
She had
common
a
problem.
history
It
of
is not.
epileptic.
Sorry.
She had a history of fatigue,
Okay.
and a history of severe
Patient is fatigue.
menstruation.
If patient is fatigue, right? History of fatigue, young female, otherwise fine, no comorbidities. How you manage? You confirm that this patient has iron deficiency for sure. So, Dr. Salika, let's get back to you. If you can't give the transfusion,
Yes.
is it emergency to give this patient the blood transfusion? So, what are
Yes,
the
sir.
yes? So,
Still,
what
yeah.
are the indication of blood transfusion? Tell me. This is how your Viva will divert.
Uh,
What are the
okay.
indication of the blood transfusion?
Symptomatic anemia,
Symptomatic
like
anemia. Fair enough. Symptomatic anemia. Absolutely. Brilliant answer. Anemia should be symptomatic or very severe even though if
severe.
somebody has a 3 grams of hemoglobin and he doesn't have much symptom does not mean you non
It's,
transfuse. So
yeah.
two or three things are important for transfusing any patient. So whenever you take a transfusion, right, transfusion decision, look at the hemoglobin, look at the symptoms, look at the comorbidities, and look at the primary disease. Primary disease. Say, for example,
Mm,
hemoglobin is 6, fatigue, comorbidity is absent, and disease is iron deficiency anemia. This is one scenario. Opposite side, another scenario. Hemoglobin is 6, symptoms is fatigue, comorbidity is absent, but disease is acute myeloid leukemia. You understand what I'm saying? Everything is
yes,
same.
Yes, sir.
The diagnosis here is changed. AML is basically a disease of stem cell bone marrow, right? So this hemoglobin will not increase by any means, right? Until and unless I'll give the leukemia treatment. So in that patient at the time of diagnosis, I may transfuse 2 to 3 unit to make the hemoglobin at least 9 to 10 gram percent baseline. Here iron deficiency, I know confirm 6 HB fatigue, otherwise fine, no comorbidities. I prefer if I want to improve the fast, I will go IV, right? If patient is not ready, I will go with the oral. If tolerates well,
Okay,
I will continue the oral till the this 6 become 12. I'll continue the oral, right? I continue the oral.
okay, okay.
Third scenario here. HB6, fatigue, comorbidity need. Patient is a 9 months pregnant lady or 8.5 months pregnancy, say for example. He has still 3 to 4 weeks to go, 3 to 4 weeks to go for expected date of delivery. In this case, I may go for IVIM. right? I'll give 2 to 3 weekly doses of IV iron to increase the hemoglobin, and 4 weeks of time is good enough. Good enough. You don't need to
Okay.
transfer the patient in a pregnancy, right? Right? If the same lady comes with a head on perineum, within 1 hour the delivery comes, right? Labor pain started just now. You check hemoglobin is 6, MCV 60, ferritin is 10, right? Patient has a fatigue, patient has a 9. I mean, just labor pain started, no comorbidities. What you supposed to do? You don't have any options. Oral iron will not increase, IV iron will immediately not increase. You have only option is PCV. Are you getting me?
Okay.
Yes or no? At least
Okay.
tell me yes or no.
Yes, sir. Yes, sir.
Yes.
Yes, sir.
Yes, sir.
Wonderful. So see how the scenario change. So always you don't need to look at the number. So never ever treat the number in any this anemia. Look at the hemoglobin. Patient is symptomatic or asymptomatic. Comorbidities, disease, right? If say patient is saying patient has a triple coronary artery bypass grafting has done, patient has COPD or patient has very bad heart failure and 6 HB with 60 MCV. In this case, I would like to give blood transfusion to increase because heart and lung are the vital organs. They need a good oxygen. Who will carry the oxygen? Hemoglobin binds with the oxygen. HbO2 go to the tissue, each and every cell. It's a transportation system is hemoglobin. So if you don't have the hemoglobin, how you supposed to transport the oxygen to the tissue and cell? Are you getting me? Yes or no?
Yes.
Yes, sir.
So only numbers is not important. That is my all take home message by giving the various examples and reasons, right? So one case I'll give oral iron, one case I'll give IV iron, one case labor pain started and 6 HB I'll go for transfusion. So it's a different story. So you need to look into the 4 5 things. What is the hemoglobin? What is the symptoms, what is the comorbidities, what is the underlying disease, and compiling all the details you decide whether this need oral. So diagnosis is same, iron deficiency anemia for same, iron deficiency anemia, right? One patient has a one same parameters. This CBC is same for everyone. If iron deficiency anemia, I may go with the oral. If not tolerate well, IV iron, that's it, increase 100%, it will increase. You don't need to give the transfusion because you find out the cause, you are treating the cause, it will going to increase kalas. If the iron deficiency with acute myeloid leukemia, I probably go with the blood transfusion. Iron deficiency anemia with 6 grams of hemoglobin with labor pain, just within 1 2 3 hours delivery happens, I'll go transfusion. If the patient has iron deficiency anemia 1 or 2 months of time through there, I probably go with IV iron, right? So see that iron deficiency is there, but what underlying condition, what are the symptoms, what comorbidities, it will change the answer. Is that clear? Yes or no?
Yes, sir.
Yes.
Wonderful. So now iron deficiency anemia is confirmed now, right? By all means, this patient, our same patient, let's go to the scenario. 25 is female, no comorbidities, 3 delivery, heavy menses, right, history of heavy menses. Now she is not bleeding. No fever, no bleeding from any side, no weight loss. Examination is marked pallor, no icterus, no lymphadenopathy, no pedal edema. Respiratory cardiovascular system, abdomen is soft, CNS, NAD. How you manage? You told you do a CBC, you do a peripheral smear, you do iron profile, which is suggestive of iron deficiency anemia, right? So now what you supposed to give to this patient? What is the treatment now? You did a diagnosis of this patient, confirm. How you supposed to treat this patient? Yes, yes, Salika.
We have to we have
How
to
you
start
want
the
to treat
patient
this
with
patient?
oral.
Now you have each and every details of the patient. How you want to treat? If I can say the symptoms, mild fatigue. Right now, patient has mild fatigue. Vital is stable. Vitals stable. How you want to treat this patient? CBC we know, peripheral smear we know, iron profile we know, suggestive of iron deficiency anemia, confirmed. Ferritin is 10, so it is confirmed. There is no other differential diagnosis. Now, how are you supposed to treat this patient? Do you have any confusion? Would you like to ask me any question?
No, sir.
Now, how you
Mm,
treat this patient?
the
Tell me.
patient, so even though the anemia is 6, the patient is stable. So
Hmm.
maybe we can start with IV iron sucrose weekly or oral iron also. As it is 6
So if I can
IV
ask you,
iron
what you want to use, IV or oral? Personally, I mean general, what's your choice in this patient? Same patient comes to you.
IV,
Probably
sir.
your choice, my choice would be different.
IV, sir. Class let me. uh, IV iron sucrose.
IV and sucrose, fine. So if I ask you why you selected IV and why not oral, just for the discussion point of view, right? Because until and unless patient is 25 years female, she is a young, na? 25
Mm,
years is female. Patient does not have
yes.
any comorbidities. It is written there, na? No other comorbidities
Yes.
is there. Patient is minimal symptom and just mild fatigue, minimal symptom, no much symptoms, no comorbidities. Why you can't start the oral iron, PO, oral iron?
Mm,
This is my
it,
logic.
the
This is my
response.
logic.
Okay. Okay.
Now you can defend, you can interact, or you can respond to the questions. I am thinking
Mm,
the patient is young. Why you want to give the IV? And he's fine. She's moving around. She's doing able to do all household activities, cooking, going to shop, taking groceries. She's routine, normal living life. Then why you want to give IVI? That is what my question is.
because
Patient is
still
young kid.
anemia is severe. Yeah.
Anemia is severe. Okay. So it will not improve with the oral iron.
It will take time, like 2, 3 months. Like after a month,
So
1 point, 1 point, like that, it might
fair
increase
enough.
after
So but
oral. But if we
but
give,
I'm not
uh,
in hurry. I'm not in hurry. If patient's compliance is good, patient is okay, I can start oral iron. And patient is refusing IV iron, what will you do? Patient say, no, no, I will not do
even
any
we
IV
can.
iron. I will
Okay.
not do any IV iron. I will not going to transfuse the blood. I am fine. I don't have any symptoms. I am working and doing my activity from morning 9 to night 12 o'clock. I don't feel anything bad. Just I am little fatigued. That's it. What do you do?
So then we can start oral iron and ask her to follow up to
Oh,
check the
good.
value again.
Wonderful.
And if
Wonderful.
she is improving, uh,
Wonderful, wonderful. So just for your knowledge, right? This is very important discussion,
okay.
and there are thousands. Everybody has the confusion in their mind, right? So people saying
Yeah.
6 HB means transfusion. It is always a wrong answer.
Yeah.
Look at the symptoms. Look at the age. Why you want to transfuse? Ah, okay. This patient is acute leukemia, or this patient has a aplastic anemia, or this patient has a hemolytic anemia, or something bad things, right? Or bone marrow suppression. In that case, I will give you directly the transfusion. Directly, right? It's a different story. So you need to see the age, the comorbidity, the symptoms. So what I supposed to do, I'll tell the patient that if you can take orally, I will start the oral iron, right? If you don't tolerate, so this is the one of the biggest problem with the compliance.
Mm,
So they may have sometimes diarrhea, they may have bad constipation or abdominal cramp. This is the commonest side effect of oral iron. So patient is not taking because of intolerance. So tolerate issue. In that case, you can go for the IV. But if patient is tolerating well, if the every month follow up, this month 6, next month 7.5, after 1 month 9, after 1 month 11.5, so within 3 4 months it becomes normal if she is taking good, if the compliance is good. It is not mandatory that you start the IV iron or blood transfusion in such patient. We are talking about this patient only right now. not any other patient. We are talking about this patient only, who is quite fit, young, no comorbidities, minimal symptoms. Is that clear? Yes or no? Yes or
Yes.
no? Dr. Fatima, any comment?
Yes, sir.
Yes, sir.
Any comment, Dr. Fatima?
No, sir.
Wonderful. So just keep in mind it is not always mandatory to start the oral
Okay.
iron, IV iron or transfusion. Depends on the case to case basis. You can decide, right?
Sir,
You can decide.
small
It is not
question,
one
sir.
answer for all, right? So once I will say,
Excuse me,
so
sir.
let's go little forward our things. Patient, you started oral iron, but after 15 days, patient comes to you 15 days, sir, I have a very much abdominal cramp, right? I have a metallic taste in bad taste in the mouth after oral iron. I have a black stool. I have a 7, 8 times diarrhea after starting the iron. It is intolerance, right? Yes or no?
Yes, sir.
Yes, sir.
Now you want to start the IV iron. You have only one options now of IV iron. What IV iron you start? Number one, what is the dose? Why you selected this? What is the cost of this? What is the advantage of this? All five, six questions I want to know. So now you tell me, Dr. Salika, first question, IV iron. So give me first name of the IV iron. Which IV iron you prefer and why?
Mhm. Iron
Yes.
sucrose.
Okay, fine. So iron sucrose. Wonderful. So this iron sucrose, what is second question? What is the dose in this patient who has a 6 HB? HB 6 and ferritin is 10 and deficiency, what dose you will give to this patient? Second question. Third question,
Mm,
whatever the dose you tell me, I will ask you what frequency, every weekly, every fortnightly, every monthly you will give. Fourth question, how long you will give to this patient? Fifth question, why you selected iron sucrose? Why not ferric carboxy maltose? Is there any test doses required or not? Is there any anaphylaxis is associated with this or not? Are you getting me, Dr. Salika? Yes or no?
yes, sir. Yes.
Many questions, isn't it? Many questions.
Yes.
So if she wants to divert your Viva on IV iron, she may ask you, okay, doctor, what is the dose of IV? It's a routine question in Oman Viva, very routine, very routine
Mm,
question. Iron deficiency. 1/4 of the world is suffering from iron deficiency anemia. Or every other woman in India is suffering from iron deficiency. Biggest problem, biggest global burden. Every house has iron deficiency. Every house has iron deficiency, especially female. Yes, Dr. Fatima, do you have any comment on this? Iron sucrose, dose, frequency, how long you give, why not FCM, why you selected IV iron? Are you going to give any test dose for iron sucrose? If yes, then how you give? If no, then okay. Is there any anaphylaxis associated with iron sucrose or not? What is the cost? Eight question. It is important. What do you think, Dr. Salika? It's important or not important?
Yes, sir.
important.
It's important. This all questions are important or not important?
Yes, sir. Important.
Wonderful. So how you manage this all questions? So now see the chart
Okay.
for your knowledge, right? So this is IV iron comparison, summary comparison of IV iron. So this is IV iron. First is iron sucrose. The maximum dose is 200 to 300 milligram, max single dose. So once you give the single dose max, right? Taste dose is not required, right? Because there is no anaphylaxis allergy. Within 15 to 60 minutes, it is fast. 15 minutes is nothing. So basically, you can give it in outpatient department. Iron sucrose, right? Key risk, any risk, very low risky drug. Pros, safe, commonly used drug, but the cons is multiple doses required. So 300 milligram, after 1 week 300 milligram, after 1 week 300 milligram, until and unless your hemoglobin is normal, you need to give multiple dose. Is that clear? Yes or no, Dr. Salika?
Yes, sir.
This is iron sucrose. Another market available IVN is ferric gluconate. You don't need to remember. What you need to remember, two good things you need to remember. One, iron sucrose, mug up everything. Second thing is ferric carboxymaltose. Whatever you
Maltose.
they will ask you FCM. It is called as FCM complex, ferric carboxymaltose. What are the advantage? Maximum dose just 1000 milligram. One dose you give 1000 milligram, all done. Taste dose required? No. This is 15 to 60 minutes. The literature, official literature is showing just 15 minutes. Within 15 minutes, you can give it this 1000 milligram, and in 250 ml, they are saying in 100 ml to 250 ml NS, over 15 minutes, you can give it. That's it. Key risk factor, nothing major. I use it. I use this agent maximum in last many years. Ferric carboxymaltose. I honestly speaking, touch wood, there is a no infusion, right? I had given in 15 to 30 minutes, no test dose. I never did it any test dose. I had given 1000, right? And I never had any anaphylaxis. I never see much clinical hypophosphatemia. It is written in the literature, but I don't know. The advantage, pros or advantage is fast, high dose you can deliver. Only disadvantage is expensive. How much expensive? Around 3,000 to 4,000 Indian rupees, right? So you give it. So I usually prefer this because patient don't want to come many times to the hospital every week, every week, every week. So it is not that costly as well. 3,000 rupees is not a huge money, right? So you can give it in single shot. It's all done. And at all, if it is required, you give one another 500 milligram dose after 1 week. That's all. Hemoglobin from 6, it will become 12.5. Believe me, within 1 month. Within 1 month,
Okay.
no transfusion is required. I did it in thousands of patients in my practice so far, right? So these are the advantage. Apart from that, there are lots of agents available in the market, but you just remember this too. So by chance, if the examiner asks you what are the IV iron preparation available in the market you knows about, then you can say ferric carboxymaltose, iron sucrose. What is iron sucrose? You can tell me. This is the dose. No test dose is required. Very safe. Infusion time is less. And you can give multiple dose until and unless hemoglobin is up. That's it. Ferric carboxymaltose. If they ask 750 to 1000 milligram, maximum dose 15 milligram, you can give it. Right? It is fast. No anaphylaxis. No test dose required. Advantage, you can give it in a high dose in a single sitting. It avoids the recurrent or repeated hospital visit. The only is the little costlier than iron sucrose. Is that clear to you? Yes or no? Yes or no?
Yes, sir.
Yes, sir.
Got my
One
point?
doubt. Uh,
Yes, please.
so like so weekly we can give, right? This weekly or
Ferric carboxymaltose is the single dose. Usually, it is sufficient, but there is a calculator. Again, there is a calculator of the iron deficiency. How you supposed to calculate the requirement of iron? Probably one patient required 1000, right? One patient may require 1500, one patient required 2000. You understand? Depends on the deficiency you need to supplement. So what is the calculator? So let's go for the calculator, right? What is the calculator? So I'll show you the calculator. So IV iron dose calculation or calculator. So iron dose, how you total iron dose, weight in kg. So if the patient is 60 kg weight, right? Are you getting me? Yes or no?
yes, sir. Yes.
Yes, sir.
Right? So hemoglobin, our patient, hemoglobin 6, ferritin is 10, her weight is 60 kg weight, right? So let's see that our total iron dose, weight in kg. So we 60 multiply by into bracket target HB. What is the target HB for this patient? This patient has a 6 HB. What
11.
is your target usually? target is usually near normal, right? If this patient comes near normal, it would be good, isn't it? Yes or no?
Yes, sir. Yes.
Wonderful. So
10.
let's say for 10, minimum 10,
10.
target 10 you want to achieve.
Mm.
So 10 HB minus actual HB. Actual HB 6, right? Patient's HB 6. So 10 minus 6. Multiply by 2.4. And for the store, additional 500 milligram you give to each and every patient. So this is mathematics. So 6 multiply by 10 minus 6. If I am not wrong, it is 4. Multiply by 2.4 plus 500. Again 6 into 6 into 4, 240, multiply by 2.4 plus 500. So let me calculate this for you. So I'm calculating in my mobile phone. 240 multiply by 2.4 is equal to 576. This is 576. So I count just generally 576 or 575. Just round off plus 500. Right? So it is 1075 milligram IV iron dose is given to this patient. Is that clear to you? Yes or no?
Yes, sir.
So say
Yes.
for example, ferric carboxy maltose you want to give to this patient. So give first
Mm.
maximum 1000 milligram, remaining 75
Mm.
milligram or 100 milligram give after 1 week. It's all done. This dose, this is supplement. To increase hemoglobin, this dose is enough. 575 is the right. If you give just 575, it becomes 10 for sure, or maybe higher. But avoid future iron deficiency. You give 500 supplemental iron, which goes and become as a ferritin. This is for the ferritin. 500 is ferritin. You understand?
Yes,
Extra
sir.
iron will remain into your body, right, as a store in form of ferritin, right? So whenever you had a, what happens if you have 12 hemoglobin and MCV is say 80 normal, because of menses it becomes 10 HB, MCV is 80, 8 HB, MCV is 80, 6 HB, MCV is 80. What will reduce is ferritin? Here ferritin 100, right? So when you have 12 HB, ferritin is 100. Then ferritin may little utilize 80 hemoglobin, right? So ferritin will fall, right? Not the MCV, right? So what happens? Our goal is to supplement the ferritin. So 12 grams of hemoglobin, ferritin is 10. It is iron deficiency anemia. But even people have 13 grams of hemoglobin, ferritin is 10, iron deficiency anemia. 14 grams of hemoglobin, ferritin is 10, iron deficiency. Just iron deficiency, not the anemia, because it doesn't fit into the anemia. Ferritin is low at the right 11 HB, 10 HB, 9 HB. So hemoglobin will change, ferritin is same. So iron deficiency is there. But when you develop the anemia, it is called iron deficiency anemia. So it's two different things. Iron deficiency, so probably I may have iron deficiency. My hemoglobin is 14, so no anemia is not there, no anemia, right? Because definition is what more than 13.5. I have 14. But if somebody check my ferritin, it's 10. So I have iron deficiency, not the anemia. But somebody has a hemoglobin of 10 and ferritin of 10, it is iron deficiency anemia. Are you getting me? Yes or no?
Yes, sir.
Yes or no?
Yes, sir.
No. Right, so this is what the basic is. So we need to understand the what is the pathology, what is the things underlying cause. So this is how we have to answer. So Dr. Salika, now would you like to finally comment on the answer, how you supposed to answer these questions? Now you have a lot of knowledge about anemia, you have oral iron, IV iron, how to diagnose, what is ferritin, what is TIBC, what is peripheral smear, how you supposed to do.
Yes.
So now this patient finally diagnosed as anemia, and examiner is saying you, Dr. Salika, you have 2 minutes for these questions. How you manage these things? 2 minutes to answer this question. She is clear cut asking you, you have 2 minutes to answer this question. You answer me this question in just 2 minutes. Think of 10 seconds, compile all the details. Everything is there with you. CBC, peripheral smear, iron profile, all details, everything Now everything is with you now. How you manage this patient? Yes.
Um, We'll start with the oral iron supplementation, and
Okay.
I will ask the patient to review for follow-up. If the patient
Okay.
is able to tolerate the oral drugs, I will ask the patient to continue with it, and I will check the iron repeat. I will check repeat CBC value after 1 month. After 1 month, and if patient returns not able to, if patient is not tolerating the oral medications, I might suggest her for IV formulations, IV iron.
Wonderful. Wonderful. So this is how you have to answer. So how I supposed to answer this patient in exam? You are absolutely right. So considering the history, examinations, and lab parameters, it is likely that this is a severe iron deficiency anemia suggested by low hemoglobin and low ferritin. I would like to start this patients on the oral iron with the proper counseling of the adverse effect. If this patient tolerates well, I'll continue with the oral iron, preferably empty stomach, with explanation of basic side effects, right? And I tell her to have a
Yes.
good compliance to take properly on daily basis. Comes to the follow-up initially for 2 to 3 weekly to check symptomatic improvement plus what is the change on the CBC. I'm expecting the hemoglobin will rise in 2 to 3 weeks. More than deficiency, more the fast increment in the hemoglobin. If the compliance is good, if the increment of the hemoglobin is good, I will continue this oral iron until and unless hemoglobin becomes normal. Once hemoglobin becomes normal, I'll supplement extra 2 to 3 months of oral iron, right? Oral iron, which will, right, for the store of the iron. So this extra iron, once the hemoglobin becomes normal, extra iron supplementation I will give to this patient, right, to replenish the store of the iron as a ferritin in the body, right? So this is how you have to answer.
Yes.
If the patient is
Okay.
not compliant, then I may probably switch to the IV iron, right? And I will monitor the patients on the same basis. If improvement is there, I'll continue. Even if patient is not improving on oral iron or IV iron, I'll try to look out on other underlying causes of this along with the low MCV and low HB. There are five reasons iron last, right? So along with iron
Yes.
deficiency, patient may have sometimes, right, bleeding per rectum. Though patient doesn't know, patient history is not proper. I may go for stool for occult blood. I may go for the endoscopy. I may and primary problem is heavy menses. So I'll try to find out the local pathology why patient has heavy menses,
Mm.
right? Because once you are giving the drug and every month is passing 7 days, 8 days, 10 days, heavy menstruation is going. So your hemoglobin will never ever become a normal. Why? Because when you increasing by oral or IV and she is losing from vagina. You got it? So along with the iron
Yes.
deficiency treatment, I'll take opinion of gynecologist, obstetrician or gynecologist to
Yes.
find out the cause of heavy menses, whether it is hormonal, whether it is uterine, whether it is fibroid, and I try to evaluate and treat the underlying cause as well, which is a cause of heavy menses. So this is how. Otherwise, what happens? Right? You are going oral iron 6 to 8, it becomes heavy menses again 6, oral iron 8, heavy menses 6. You understand? So you need to treat the iron deficiency anemia, all right? And cause of iron deficiency anemia is heavy menses. So you supplement the oral iron or IV iron. Same time you go and treat the heavy menses. Who will going to treat the heavy menses? Gynecologist. He will
Thank you.
evaluate, he will consult, he will find out the cause, and he will treat it. So your both problem now, no heavy menses, no anemia, HB is 12, patient is fine. Is that clear, doctor?
Okay, sir.
Yes.
Yes, sir.
Are you getting me? Yes or no?
Yes, sir.
Yes, sir.
Wonderful. Did you get the Fatima, doctor, idea how
Yes,
we
sir.
supposed to evaluate an answer? So we have
Yes,
a
sir.
next session with the same thing. So read two things. Homework. I will give you homework every time. Homework. What's the homework? Read the whole complete chapter of anemia with all causes. We have seen iron deficiency anemia. Next time we probably see B12 deficiency anemia. We see the sickle cell anemia. We see the thalassemia. These are the common high yield questions. Sickler and hemoglobinopathy is common in Middle East countries, especially Oman. So they may ask you, right? So all things related with sickle cell anemia, disease, trait, thalassemia trait, thalassemia minor, thalassemia major, how you diagnose, how you treat. So read it. You have 2 to 3 days of time. I will announce my next lecture to both of you and three of you in the group. So just keep in touch with me. And before I end up my session, I
Okay.
would like to have quick feedback on this session. How did you enjoy it? How did you learn? Still, we learn a lot of things together in next 1 month, right? With me and my other colleague as well. So how was your approach earlier and how is the approach now? What did you learn? Yes, Alika.
That your
What did
voice is breaking.
I'm saying? I just want to understand how did you learn and what did you learn in today's session? How did you enjoy it? Any learning?
Sir, I couldn't hear you. Your
1 second. Hello. Now am I audible?
Yes, sir. Yes, sir.
Am I audible?
I think Dr. Shalika is not here.
Okay. Yeah, Fatima. So
Yeah.
how did you enjoy it?
A very useful class, sir.
Wonderful. So
Yeah,
students
like
have learned.
how we have to approach a patient in a stepwise manner, like
yeah,
from the history and then
very good.
examination and then the treatment based on their uh, clinical symptoms, whether to start
Wonderful.
on IV or oral.
Wonderful. So this type of questions comes in the Viva very quickly, right? Because like the OMSB or Pearson, you don't have any options A, B, C, D. You have to answer directly. You understand? So you
Mm.
need to be
Okay.
prepared with the basic questions. So get ready with all the things what I had given you the homework. So we'll see you in the next class. I will announce soon. I'll check out my schedule and get back to you. Right?
Okay, sir.
Okay.
Thank you so much. Thank you
Okay,
so
thank
much.
you very much and
Thank you so
best of
much.
luck. Just
Thank you so
revise
much.
this. This is 99% they will ask you this question, iron deficiency or
Okay.
hemoglobinopathy. So we don't need to miss it. If you answer well, almost you are
Okay.
pass. Just one question. So I'm
Okay, sir.
covering high yield. Rest of the things you can do it.
Okay.
All right.
Thank you.
Thank you very much. Okay. Bye. Take care.
Thank you, sir.
Thank you. Bye. Take care.